there, everyone. Thanks for joining us. It's great to see everybody. And I think we're probably going to get a few more people coming in. Tiffany's letting everyone in. My name is Leslie Frank, and I'm sitting in today for Dr. Tiffany B. Grunwald, the Executive Medical Director of the Women's Health Institute and the Division Chief, of Plastic and Reconstructive Surgery at Providence St. John's Health Center in Santa Monica. That's a mouthful because she has so many incredible titles, and she's a tough act to follow, I have to tell you. But we are very excited today to have our special guest, Dr. Nicole Weinberg. Dr. Weinberg is a cardiologist at Pacific Heart Institute in Santa Monica. Welcome, Dr. Weinberg. Thanks for joining us today for a conversation about women's health, women's cardiac health, something that can sometimes be overlooked, right?
Oh, absolutely. No, this is an absolute pleasure. And I so appreciate you guys having me come so we can highlight heart disease and an awareness to it, because there's so many aspects of heart disease that are really preventable. And so the more you know, the more powerful you are.
Fantastic. And we hope to answer all of your questions in the next hour. I just want to mention that we are recording this session and it will be posted on the Women's Health and Wellness Institute Facebook page. And that's also an opportunity for you to view previous conversations on women's health and the various topics of discussion and aspects of women's health. So that's on the Women's Facebook page. Again, my name is Leslie Frank. For those of you in the Los Angeles area, you may remember me from my days as Leslie Miller at KABC, where I was a reporter and anchor for almost a decade in LA. I've been out of the business for a number of years, and I'm coming to you from my home in Napa Valley. My husband and I own a winery here, Frank Family Vineyards. You may or may not be familiar with it. So I've transitioned from the news world into the wine world, but I will try to use my skills as a reporter and an interviewer in my previous career to try to answer all of your questions today. So, Dr. Weinberg, you have a true interest, obviously, in women's health and how cardiac disease presents itself and how it's treated differently in women. And you host an amazing symposium each year on women's heart health. Can you tell us a little bit about yourself and your training and your practice?
Yes, well, absolutely. So I came to Santa Monica after my training at Harbor UCLA. I really had a passion for prevention, and I really wanted to do non-invasive cardiology. So that's imaging, ultrasounds, CAT scans, stress testing, things like that. And so when I started at Pacific Heart Institute, I was the first woman in the practice, and I was getting all of the referrals of the female patients, the pregnant women, the hormone change, the prevention, because I have a family history, but everybody always thought, well, it's a male disease, so I probably won't get it, but what if I get it? And so I really amassed all these really interesting patients, and I found that I was saying, kind of a lot of similar stuff, and it was a little, warmly welcomed by people in that they felt like these are things that they hadn't heard before. And then a few years after they had hired me, they hired an electrical specialist, an electrophysiologist within my practice who was a woman. And the two of us together found that we were seeing similar patients and having all these fantastic dialogues with people. And we were feeling like, this is like a great energy that we're creating here within the world of medicine, within the world of women, within the world of women's health. And we would oftentimes see patients back to back. And so we realized, we think that this is very normal and completely usual, but it's obviously not to a lot of people. So we kind of took our show on the road, and we started a Women's Heart Center, and which ultimately formed a Women's Heart Symposium so that we could kind of broadcast a lot of the things that we were saying. So we have speakers come from all over the country. Our Women's Heart Center has grown. It's not just myself and Dr. Vanderzee is the electrophysiologist. There's another non-invasive cardiologist, Alexandra LaJoy. We're three women in a practice of cardiology, which is pretty unusual, actually. There's not a lot of women within the world of cardiology. And so we see a lot of women's health issues. We deal with a lot of pregnant women, hormone change, risk factors for disease. How does this testing affect me differently because I'm a woman than my brother, my husband, my dad. And so we've ended up really amassing quite a crew. We feel so lucky to be part of this community and be able to work towards some good prevention for our patients.
I think part of good prevention is also dispelling some of the myths surrounding women's health. And one of those myths is that the leading cause of death in women is breast cancer. And that's not true.
So it's interesting because when I first heard the statistic as well, I thought, no, it's not. It's breast cancer. But it's not. The leading cause of death in women is heart disease. It's also the same leading cause of death in men. And if you look at number 2, 3, and 4 in terms of the second, third, and fourth leading cause of death, and you add them all together, it still doesn't equal the same number of people that are dying from heart disease. So it's critical that we identify our patients that are at risk so that we can treat them. It'd be so great to lower that from the leading cause of death. It's the only thing in the entire world that we just don't want to be first in. We'd love to be second or third or fourth or 10th, but unfortunately we've been first. We've been the leading cause of death for a number of decades.
Mm-hmm. Let's talk about what exactly is heart disease and how do you know if you're at risk for it and what are the symptoms?
So there's different types of diseases that fall under the category of heart disease. 50% of people with heart disease generally end up with some sort of coronary artery disease. So I think of the heart like a house. So the coronary artery disease is like the plumbing. So if there's a problem with the plumbing in the house, there is blockage in the tubes that are bringing blood flow to all the different parts of the heart muscle. So that's something that if you have that can lead to a heart attack, that can end up requiring angioplasty where you put stents in or bypass surgery. So that's kind of the leading thing that we look at. A lot of women end up not necessarily having like these big heart attacks where you end up with blockages. They have little ones in the smaller vessels, and they may end up with something called congestive heart failure. And so that's when you kind of knock off little parts of the heart muscle along the way. You get these little small heart attacks along the way, this little damage that ultimately makes the heart muscle not function well. So then the squeeze of the heart or the relaxation components of the heart become impaired. So that comprises a lot of patients that end up with heart disease. There's also valvular heart disease where the valves, I think of that like the doors of the house, you know, they don't open and close very well or they leak quite a bit. Those are things that might ultimately require some procedure therapy so that you're not having such a degree of leakage of the valves or blockage, because clearly you need the doors to open and close well to move blood around the body. And one of the other things that we see a lot these days is electrical dysfunction. So arrhythmias, and I think of that again, if we look back to the house, we think about the electrical current moving through the heart muscle, and you can end up with things like atrial fibrillation, which 25% of Medicare patients end up being diagnosed with, supraventricular tachycardia, ventricular tachycardia. So we look for all of those different disease states, and all of those things fall under heart disease.
How much of it is genetic and how much of it is within our control, diet and exercise?
So it's a great question. And all of those different features of heart disease kind of have their own components of both genetic and lifestyle issues. Everybody is different. So I think about the risk factors of your different disease state being like pieces of the pie. So how big is that piece of the pie? Well, your genetics may be greater than 50% of a piece of a pie. If like, say every member of your family has blocked heart arteries, you may say, well, it's because they, ate poorly and didn't exercise and whatnot. But the fact of the matter is, if these are your genetics and everybody in your family had that, you may try to lower your cholesterol with diet and exercise. And truly, the likelihood that you're going to lower your cholesterol beyond about 10 to 14%, which is kind of the statistical norm with diet and exercise, is very low. So that may be something where we really just need to say, okay, well, I think that's wonderful that you eat healthy and exercise, and it's going to be good for your heart and it's going to be good for your body, but it may not be enough to prevent your body from depositing plaquing in your arteries, for example.
So genetics really do play a big role in it. It can be hereditary.
Exactly. And then if you think about, the patients that may have a lot of family members with valvular heart disease. There's a lot with valvular heart disease that's genetic. You may be born with an aortic valve, which is the valve at the top part of your heart that's supposed to have 3 cusps, 3 leaflets that open and close. Well, a lot of people that are born may end up having just 2 cusps of their aortic valve. or some sort of other genetic condition that makes the way your body forms the leaflets in a slightly malformed way. And so you may end up finding, people on both sides of the family have a lot of need for surgical repair of their valves. That's not something you can diet and exercise your way out of, unfortunately.
Right. Okay. So in order to maintain the best heart health, how can we be proactive in our health? What are the tests that we should undergo on a regular basis? And should we be just seeing, our general practitioner, or should we be seeing a cardiologist for heart health on a regular basis, the annual basis?
So, says the biased cardiologist, I always think a good exam from a cardiologist is really very optimal. I think it's always good to have your cholesterol checked. For most adults, we say you should have your cholesterol checked annually, unless there's significant weight changes or new diagnoses like diabetes, certain autoimmune diseases, or things that contribute to a lot of inflammation may change your cholesterol. A good EKG is something that's really important, and that's just when you put the stickies on your chest and you make sure that everything looks okay. And again, I believe that's something that should be done once a year. So those are things that I think are not unreasonably done to be done in a general medicine doctor's office. I think what is so interesting with prevention, and then also with having a lot of data, is when you follow somebody over time, you can see, oh, well, your cholesterol looked like this 10 years ago, and we've just kind of been watching it kind of slowly change over time. Maybe it's time to evaluate this further, especially in light of your family history. So I think a good general medicine doctor can kind of put some of those pieces of the puzzle together and determine when it's really appropriate to see a cardiologist. Not everybody has a good general medicine doctor that they count on. Not everybody is, in a situation where they can kind of navigate those things. And I think a consultation with a cardiologist is always very reasonable, especially if there is a significant family history or some sort of unusual symptoms that don't seem to be rectified with kind of like a basic workup with, basic blood work or basic evaluations like a chest X-ray. I think a lot of people think that they come to the cardiology office, you're going to end up with a cardiac catheterization or bypass surgery. And I feel like it's very funny when patients come in, I'm always saying, okay, don't worry. I don't think you're going to need a heart transplant. Let's figure out what we need to do to get you to feel better. It doesn't always have to be doom and gloom in the world of cardiology. There's a lot that we can do to evaluate people, make them feel better, that doesn't require invasive testing, radiation, injections, contrast dye. I think the world of cardiology has really advanced over the past few decades, and we can get a lot through non-invasive imaging.
I have a couple of questions here. Speaking of invasive testing, what is a non-invasive cardiologist?
Okay, sorry about that. So a non-invasive cardiology does no cutting. So I appreciate blood through imaging, but I don't actually see a lot of blood. So I do things like echocardiograms, which are ultrasounds of the heart, checking the structure of your heart muscle, looking at the valves, looking to see if there's thickening or dilation to your valves or your aorta. We also do stress testing. So whether it be exercise on the treadmill, or sometimes we use pharmacologic agents, drug therapy, to help mimic what exercise would do in the body. There's also CAT scan imaging. So we image people's hearts to be able to look at their arteries, to look at the functional status of their heart. There's also cardiac MRI now. So we can really see all sorts of nooks and crannies in the real cellular level of the heart muscle. So those are some of the studies that I look at.
Right. And again, these are tests. Should these be done on an annual basis, or it really just depends on your overall condition of health and your genetic makeup?
So it depends. I think a good normal study, if it's really stone cold normal and somebody has no symptoms, these tests have really good predictive value, some of them between 5 and 10 years. But if you find that you do a study and somebody has like a little valvular issue, or they have plaque buildup in their arteries, you may not want to wait that long. So assuming everybody's feeling well, you may wait 1 to 2 years. I think that's the issue with a lot of cardiac testing and maybe a lot of medical testing. We love a lot of points along a line to be able to follow disease. Let's just say, for example, that a patient comes to me because they have a murmur on their physical exam, and we do an echocardiogram, we do an ultrasound of their heart. We find, well, their mitral valve is a little bit thickened and maybe has a little bit of leakage associated with it, which we may call a mitral regurgitation, because we don't have great words to use to describe things in cardiology. But so let's say we say they have mild mitral regurgitation. I would still examine them every year, and I might repeat an echocardiogram every, 2 to 5 years based on their physical exam. The flip side of that is if they come to me and they say, now I'm really short of breath. I'm normally exercising. I usually, can walk a mile every day. Now, when I feel like I'm walking, I feel really breathless. Or, what I've noticed lately, I have a lot of swelling in my ankles. I didn't have that before. I would not necessarily wait, some sort of standard 2 to 5 years. If somebody comes to me 1 year afterwards and they say they have these new symptoms, you go do a good physical exam, and then you decide if they're going to need repeat imaging.
Okay. Another question here in the chat section. And I do want to encourage our viewers today, if you have any questions, feel free to type them in the chat section and we will get Dr. Weinberg to answer them for you. One question, if I have a mitral valve prolapse, will I need surgery someday?
So that's also a really good question. Now, back in the 90s, everybody was diagnosed with mitral valve prolapse. It was like a really popular diagnosis within the world of cardiology. It had to do with the way the valve looked. It was kind of a longer valve leaflet, and it had a little bit of a floppy appearance to it. Now we've come up with very specific criteria that are met for mitral valve prolapse. There need to be certain measurements that are achieved to be something that we consider to be clinically significant. So if somebody has clinically significant mitral valve prolapse, that's something that we follow very closely, because usually the leakage associated with it will progress over time. And so once somebody has progression of disease, they end up having more leakage of that valve because the tips of the leaflets don't come together as well. And with that backflow of blood ends up being increased pressures within the heart, not blood pressure per se, but pressures that we measure on ultrasound. And those are things that we look at very seriously when we're following somebody with mitral valve prolapse disease.
Okay. Another question here. What is electrophysiology and what does it have to do with the heart?
So electrophysiology is the study of the electrical current within the heart. So every cell within the heart muscle can fire, it can beat, but typically we have these areas of the heart muscle that have a more stronger propensity to beat. So we have different electrical impulse sites that usually make the heart beat normally. But within reason, every cell within the heart can fire. And when you have either extra beats come in or some sort of dissociation of the electrical impulses, you can end up with arrhythmias, such as atrial fibrillation, such as supraventricular tachycardia, such as ventricular tachycardia. A lot of times when we are following people in our office, we see changes within their heart muscle that give us a clue. This person may end up in AFib, and we try to identify them before they end up having a clinically significant event. So for example, if somebody is having further dilation of one of the chambers of their heart, such as their atria, the chamber gets stretched. And as it gets stretched, the electrical impulses through it start to become a little bit more chaotic. So those are some of the things that we look for. We try to identify with our patients so that we can figure out if there's somebody who's going to require some sort of electrophysiology workup before they actually come into the emergency room having a stroke or a cardiac event from their electrical current problem.
Okay. Dr. Weinberg, the conversation today is about women's heart health, but are there any tests or screenings that are specific to women?
So when I first started in cardiology, I was seeing a lot of pregnant women that were having unusual palpitations, heart flutters. And so we had these old Holter monitors. I'll never forget what they looked like. They were these big, it was like strapping a phone to your chest, with all these wires. And I thought, oh, and then the device would hang over your belly and it would like flop into your belly as you're walking around. And I thought, well, I have to put this on all our pregnant women. This is so cruel. Like, of course they're going to feel awful and they're going to feel like they're patient and they're going to maybe even have a worsening response just because they're so uncomfortable. So my partner, Dr. Vanderzee, and I were working with certain heart monitor companies that would just put stickers on the chest. So you could then just wear a sticker, and within the sticker, there would be a little battery, and you could just download all the data to your battery. And so we were one of the first practices that was looking at patients with these sticker monitors, because we felt like the old-fashioned monitors were so cruel to use on our pregnant women. Another example of something that we have been doing within our office, and it's a little bit of a pilot program that I've been working on, is that with stress testing, you can't always wear a bra. And so if you're exercising and just doing a regular treadmill stress test, you can wear a bra. But if you're doing a stress echocardiogram or something that requires imaging of your heart, where the bra sits is very much where we need to ultrasound, because your heart is right behind your breast tissue. So we've developed a bra that women can wear when they're doing a stress testing that has certain cutouts and Velcro parts, but it also keeps you well supported while you're exercising. And you can imagine a scenario where you're put in a room and you're told you have to exercise on a treadmill without a bra, and you may not necessarily have me in there. You may have like a man
Right.
watching you exercise. I mean, just picture how uncomfortable that would be. And then you're told, oh, just exercise to your maximum ability. It's no big deal. I mean, these are things that you just don't think about as you're training and you're going through the process. But when you're really seeing a lot of patients every day, you realize, this is a personal experience, and you really want to get the best information you can get from your patient. You don't want them to be embarrassed. You don't want them to be in pain. You don't want them to feel like they can't, do the study, because really the best studies are going to be the ones where, for example, with a stress test, where we can really get the patient's heart rate up and get them to really exercise well. So those are two examples that are just right off the top of my head of things that we can do specifically for our female patients.
Well, speaking of exercise, Lauren has a great question. I love this question. Can you over exercise your heart? Can you do too much cardiovascular exercise and push your heart too hard over time, even if you're fit? Great question, Lauren.
So there are interesting studies looking at patients that are ultra marathoners. So these are people that are doing a lot of anaerobic exercise on a very regular basis. So I kind of think of them as an extreme. I don't know that that's what Lauren's referring to, but just for the sake of argument, look at the extreme. When you look at the patients that are ultra marathoners and you do CAT scan imaging of their heart, they have a higher coronary calcium score than people that are just doing regular exercise, despite very similar risk factors for disease. So there's some sort of process therein that is causing increased calcification. I'm not saying it's because they're running a lot. I'm not saying it's because they're exercising. I think this is something that we need to really understand and correlate, because the leading cause of death in athletes is heart disease. And
Right.
so we can't ignore that. Additionally, there are very interesting studies on the rates of atrial fibrillation in young athletes. And so I think, if you watch the news or you read any news stories, you can hear about young professional athletes developing an arrhythmia, or just watch TV and see them all pushing Xarelto and Eliquis on TV. These are young athletes that are doing cardiovascular exercise. They are more than likely, although I'm not their doctor, dilating their atria with their degree of cardiovascular exercise, stretching their heart muscle, and ultimately going into AFib. I cannot tell you the exact true mechanism of action, but the incidence is quite significant, and it's something that we're paying more and more attention to.
That's really interesting. One would think that your coronary calcium score would be lower as you exercise, not increase.
Well, again, these are ultra marathoners. So these are people that are running hundreds of miles during the course of a year. So this is maybe not just the weekend warrior, but I think in Southern California, people think, well, I'm super healthy. I run, I'm vegan, I, do all the basic testing. There's no way I could have cardiovascular disease. And we found, that's really just not the case, especially for our patients that exercise a lot. Just dialing back to kind of the rudimentary data, if you look at people exercising, I generally tell people to shoot for heart rate goals that are about 220 minus your age. So let's say you're 20 years old, you're going to be shooting for a heart rate of 200 beats per minute. That should be your max with exercise. So I think the other thing, for Lauren or maybe anybody who's thinking of exercising, if you find that your goal heart rate is consistently above that while you're exercising, you may also want to dial into your cardiologist just to make sure that your heart is not being strained with that level of exercise, because we obviously don't want to overwork your heart muscle.
Right. All right. We talked a little bit about the coronary calcium score. Can you just sort of elaborate? I'm not sure if everybody on this Zoom call today, Facebook Live, understands what a coronary calcium scan is. Can you explain what it is? I just had mine on Tuesday. I don't have my results yet. My doctor told me that he's expecting a 0 score, and because he said I'm at the age where I shouldn't have anything higher. No pressure at all. But can you sort of explain what it is and what it does?
So a coronary calcium score is a CAT scan study of the heart. There is no IV. There's a very little bit of radiation, and you pop through the CAT scanner. The CAT scanner, again, just for review, is like the donut radiology study. It's not the tunnel, which is the MRI radiology study. So it's a real quick study. It's a breath hold study. So you hold your breath, you pop through the CAT scanner, and a radiology program just images you and looks to see how much calcium deposits there are on your heart arteries. And then that is put into a program that ends up comparing you to other people that are your gender and your age group, and it gives you your percentile risk. So your doctor wants you to get a 0 coronary calcium score because he or she is hoping that you have no hard plaque within your arteries. So that person likes you and wants you to have no plaque buildup in your arteries, which is great. But within reason, whenever you do a study, you obviously may end up with some plaque buildup in there, and it's good to know sooner than later so that you can combat that. I think about it as probably one of the greatest inventions that will hopefully help us screen our patients for cardiovascular disease and really identify people that are at risk, especially for those that are presumably, healthy, or maybe feel like, their genetics don't really have interplay with their heart health. The biggest limitation that I find for patients with a coronary calcium score is not every insurance covers it. And so for a lot of patients, it's, kind of cost prohibitive around, and I don't know what our catchment is for this call, but around here, I think that people usually pay a little less than $200 for it, but that's, can be quite substantial for a lot of people that are curious.
Right. And so when should someone get this done? When should they get this coronary calcium scan so that we can have a baseline and work from there? Is there a certain age that we should start adding that to our annual health maintenance program?
Well, so again, if you ask the biased cardiologist, yes, I think it would be a wonderful screening test. And again, I think it's something that behooves the insurance companies, because if you think about how expensive cardiovascular disease is for the population, if we could identify patients ahead of time, it would be just a wonderful thing. The research studies looking at coronary calcium score generally start at age 40. So it's not to say that at 40 years old, you should run out and get a coronary calcium score. A lot of that started because cardiovascular disease generally starts in age 50 or above as hormones start to change in men and women. And so the concept was generally to check it 10 years before. So if you check your coronary calcium score 10 years before, you identify your patients at risk, you treat them. So hopefully within that 10-year period of time, you are modifying their risk factors for disease such that you prevent them from having said cardiovascular event that they would have, at the 10-year period of time. The way I usually use it is not to say, oh, let's just take, the earliest family member that had cardiovascular disease and subtract 10, but it's part of kind of a global assessment. If there's a lot of family members that have cardiovascular disease in their 40s, like, I'm not going to wait till 40 to do the study. Or if somebody has something like familial hypercholesterolemia, which is really such a genetically high cholesterol level in their system, that may be something that you want to check sooner than later. The only thing that I will say is there is some radiation associated with the study. So it's something that I don't do in patients that are pregnant, trying to get pregnant. Those are things that we would significantly want to avoid. And additionally, it's a study that, because there is some radiation, we don't do on an annual basis. So it's something that you want to do kind of at the right time for the right patient and repeat it in the right interval. It generally does have about a 10-year predictive value, but somewhere between 3 and 5 years is when you start considering repeating it again, depending on how well cholesterol has been controlled, risk factors for disease, and things like that.
Okay. I think I was muted there for a minute, and I apologize. I'm not quite sure how that happened. Okay, which brings me to my next question, Dr. Weinberg. I have a question here. Someone is asking, should I ask my primary care doctor to see a cardiologist at what age? So we talked about maybe 40s for the coronary calcium scan, but to see a cardiologist in general, what age should we consider that?
So I think people should ask to see a cardiologist if they have a significant family history of cardiovascular disease, or if their cholesterol or blood pressure is starting to elevate such that their risks of cardiovascular disease are starting to increase. So from my perspective, those are good times to start to get baselines on what's going on. So if somebody is having their blood pressure elevate or their cholesterol elevate, or they have a significant family history, you would want to dial into those people ahead of time. Because again, like we had talked about, heart disease is the leading cause of death, but there are a lot of aspects of it that are preventable. So if we could identify these patients ahead of time so that we could prevent them from having some sort of disease, then they're golden. They are going to be prevented from having anything. It doesn't mean that they won't be on medications, but we can hopefully reduce their risks so that they don't experience what their family experienced.
Okay. Let's talk about heart palpitations. I have a question here. Is having heart palpitations normal around midlife for women, and what does it mean?
So palpitations are generally abnormal heartbeats. So you can feel them in any sort of different way. Some people have just a second of like an abnormal beat. Their heart is beating around regularly, and then they feel like a little something and they wonder, like, do I have to cough? What's going on? Some people can feel like something that like lasts a little bit of time, like maybe, a few seconds. Those things kind of fall under what I would consider to be palpitations. Palpitations can be from a lot of different things. So they can be from thyroid disease, they can be from electrolyte dysfunction, they can be from sleep issues. They can also be from hormone change. Hormone change can be related to any types of changes in estrogen, progesterone, testosterone levels. So we do see a lot of women that have abnormal heartbeats around pregnancy, around perimenopause and menopause. That could be from a lot of different issues relating to whether it be hormone change or sleep change dysfunction.
What about
that is
stress and anxiety?
Stress and anxiety. People think, oh, well, it's just in my head, and now I'm getting a palpitation. Really, it's not in your head. It's a very organic problem. When you have stress and anxiety, you may have changes in your cortisol levels. Your adrenal glands may be going a little haywire. There's very organic pathologic conditions that go on with that are not just in your head. So really identifying those things will help you to treat them. And then I also think what's also really wonderful is when you learn your body, like, okay, I am really stressed, or I am, having this hormone issue, or I, have this sleep dysfunction. And then, okay, well, now I have this is what it is. This is how I treat it for this period of time, and then it goes away. You're empowered to be able to take care of yourself and not send yourself into a panic, and, hopefully be able to avoid the emergency room. And I think a lot of these things are the reasons why it's so wonderful to be able to dial into people, figure out what's going on, identify it, and just give yourself a treatment. When I think about my patients during the pandemic that were kind of armed at home with their little cabinet of like, oh, I'm gonna take this if I have this, or I'm gonna check my blood pressure if I have that, or I'm gonna use my my Apple Watch when I have this situation. it's so good to be armed when you know what your body is trying to say to you, and then you can treat it. It's very empowering.
You mentioned hormones, hormone replacement therapy. What impact, if any, does that have on the heart?
So treatment with hormone replacement therapy was hugely controversial in the early 2000s. There was a big research study that looked at people on oral hormone replacement therapy and showed that those that were on oral hormone replacement therapy at higher doses had increased risk of blood clots and stroke. So the pendulum then swung completely in the other direction. No oral hormones. It was really bad. Don't go on hormones. You're going to have a stroke. Now we're starting to realize, well, maybe some hormones are not that bad, and maybe there's an end that justifies the means. So a lot of patients are being assessed during the time when they are having hormone change to see what are their changes, what are their risk factors. If they have some cardiovascular risk factors, we generally like people to be on some topical agents. We generally believe the absorption is a little bit less and the impact to your heart and your vasculature is a little bit kinder. But for people that require oral therapies, we generally do a pretty extensive cardiovascular workup just to make sure that their risks of having a rupture of a plaque in their arteries, that their risks are low associated with that. Their risks of blood pressure change issues, their cholesterol issues are very low. And so that's kind of how we assess patients that need to be on hormone therapy.
Okay. Stephanie Weston has a question. She's asking, can you lower plaque buildup without intervention?
So the sad story is there is no Drano. That is something that's being researched really heavily within the world of preventative cardiovascular disease. We'd love to get, a pill that you take and it just pulverizes all the plaque in your arteries and then that it goes away. Unfortunately, that doesn't exist. Plaquing that's there, we think of it like cement. It's there. It's not going anywhere. The biggest thing that we want to make sure that doesn't happen is that it gets substantially worse over time. And so that's pretty much our mantra for treatment at this time. If you've got plaque, if you get your score back and it's, something that's that identifies a little bit of plaque, it's not going to go in the other direction, or at least not at this period of time. There's no treatment to get you there, but the hope is that over time, it's not going to increase at a rapid clip with some sort of interventions.
Okay. Don't they also do the carotid artery test for plaque buildup as well?
So a carotid ultrasound is maybe what you're referring to, where they do the ultrasound of the neck vessels. That's a great study. We love that. It tells us about whether plaque is being deposited in the arterial system. I'll bet for the cerebrovascular system, we use it as kind of a marker of disease. So I love a carotid ultrasound because it tells me if a patient is depositing plaquing in their arterial system. We use it as a marker of disease. So if they've got it here, we generally think that they will probably have it here, but not always 100% of the time. The other thing that I love about a carotid ultrasound is there's no radiation, and it's a really easy study to do in the office. You just pop the probe on somebody's carotid artery and you take some pictures. So it's a really easy study to perform.
Okay. Leanne is asking, Dr. Weinberg, can you ask about the impact of chemotherapy? And this is clearly proving that I'm not a doctor because I can't even pronounce this. Adria myasin cytoxin in particular on the heart. So the impact of chemotherapy on the heart.
Right. So there are certain chemotherapies like adriamycin, which are really toxic to obviously all of your cells. The whole point of chemotherapy is to kill the rapidly producing cancer cells, but it can be so strong that it also damages other cells in your body, including your heart muscle, the tissue in your heart. So when people are on certain chemotherapies, their oncology doctors like them to come in to get an echocardiogram. They can do it in our office or at the hospital. But we're generally looking at the squeeze of their heart muscle, their ejection fraction. That's how your body squeezes blood out of your heart through the rest of your body. So people know that, what's my ejection fraction? A lot of patients that are undergoing chemotherapy all want to know what their ejection fraction is, and you want it to be within a normal range. The advances within the world of echocardiography, so imaging that we do, are that we are looking to see if there's damage to the heart muscle before you actually end up with a reduction in your ejection fraction. So there's a variety of different parameters that we look for now within the echocardiogram to be able to see, is somebody starting to have some cellular dysfunction before they actually have a squeeze dysfunction. And that's something that we use with our oncology colleagues all the time.
Okay. I'm moving on here because we have a number of questions. Lily is asking if you can talk about the relationship between LDL, HDL, and the ratio calculation.
So LDL is low density lipoprotein. That's the bad cholesterol. Generally, lower is better. HDL is high density lipoprotein, and generally higher is better. And once upon a time, there was this ratio thing. It was really popular. You wanted your score to be within a certain range. From my perspective, that's very much fallen out of favor. People generally look at the numbers as individual parts. So you want to treat your LDL as an LDL disorder. You want to treat your HDL as an HDL disorder. You want to treat your triglycerides as a triglyceride disorder. I generally don't pay very much attention to the total cholesterol because, again, if you have a really high HDL, a good cholesterol, it gives a falsely elevated total cholesterol because that's an additive number. It's a calculated number based on the three parts, LDL, HDL, and triglyceride. What I have found to be most helpful in the world of blood testing for cholesterol is something called advanced lipid testing. And this is maybe taking it a little bit of a step further for the person asking the question, but there are better ways to look at your cholesterol now than just a screening test of LDL, HDL, and triglyceride. I think it's great for somebody that's, average risk or maybe has no risk factors and is just undergoing kind of a basic physical. But for those that are at risk or for those that have high cholesterol that are worried that it's elevating at some sort of rapid clip, there are other tests called advanced lipid testing that can look at your cholesterol in a more specific fashion and be able to determine what are the increased risks associated with having higher cholesterol levels.
Okay. And should you get cholesterol studies every year? And at what age should you begin getting your cholesterol checked?
So I believe they should be checked annually with your physical, and I believe they should be checked. They usually say you should start having them checked in your mid-20s or earlier if you have had some sort of significant risk factors for disease. The American Society of Pediatrics recommends a screening study somewhere around age 10. And so I think for patients that maybe have been diagnosed with these familial hypercholesterolemias or some sort of really high genetically predisposed cholesterol reading, should be having them checked sooner than that.
Okay. Can you just run down for us? We have probably about another 15 minutes or so. We talked a lot about genetics and the role that plays with our heart health. Can you give us just maybe some bullet points, some guidelines of what we can do as women to just maintain or improve our heart health in our daily lives, whether it be diet and exercise, and what specifically should we be tailoring our lifestyle to for the best results, for the best heart health?
So I love when my patients come in and they say they exercise regularly. It does not have to be crazy exercise. It doesn't have to be, ultra marathon. It doesn't have to be anything crazy, but even if it's just walking. And if you look at the guidelines within the American Heart Association, they recommend 30 minutes of walking a day. It's nothing crazy. So I love it when my patients exercise. It to me is like a daily stress test. You're kind of giving an assessment of what's going on in your heart. I love it because when my patients come in and they say, well, I'm short of breath, and I don't know if it's from my mask or whatever, but when I go for a walk, I feel great. Done. This is not something dangerous or bad. It doesn't mean we're not going to work it up, but I can tell you, I can provide some reassurance throughout the land that your heart is not the thing that's supremely compromised and causing your symptoms. So exercise, I think, is great. And again, it doesn't have to be really aggressive exercise.
And is it daily? Is this 3 times a week, 5 times a week? What's the magic number for the best results?
So the American Heart Association says 5 days a week. I say daily because
okay.
What the heck? But, I think the nuts and bolts of it are, you kind of want to keep yourself moving. I think of it like, well, we're parking in a parking lot, like park far away, walk to the door, walk back, carry your heavy groceries. I mean, those are the things that I feel can be really helpful as just kind of a little like your own little stress test, like, how do I feel with this? Okay, I feel worse than I used to feel. When I hear my patients say, well, I used to be able to walk around the block like no problem. And now I can barely walk to the corner without feeling like repeatedly debilitated with that level of exertion. That kind of piques my interest. So I think, a good amount of daily exertion is wonderful from my perspective.
Right. Well, I think being sheltered in place the last year, we've all become very familiar with this Zoom format. And many of us have been, I'm talking about myself really, have been sitting way too much, doing this a little too often, and maybe not getting as much exercise as normal. And just what you're saying, the simple things, walking to your car, taking the stairs, not the elevator, things like that. But we've been spending a lot of time at our homes and maybe not being quite as active as we even knew we were before sheltering in place, before, life before COVID.
Yes, I know. It's so true. And when I think about exercise and I think about what I did, I'm going to even just say it like to my body, as it relates to exercise before COVID, it was like you had to go to the gym and it was almost like it had to be like you had to be in pain afterwards, or at least I felt like, it really has to be this like really vigorous workout. It really doesn't need to be a really vigorous workout. It can be a walk around the neighborhood. It can be a walk around the neighborhood with your mask and your friend with their mask, and you guys can, do that. And I mean, in Southern California, we have a lot of hills. So, I think it just doesn't have to be super complicated. And I think your orthopedist will be happy because your joints will probably be better. And, you may find that there's a little even less inflammation in your system. Like I do feel like, from my perspective, I think sometimes, gut health feels better, immunity is better, joints are better. I guess I feel like within reason, it doesn't have to be so complicated.
Okay. So we talked about the exercise aspect. Let's talk about the diet.
So I think diet is important, and it's hard because I used to practice in a different city. Let's just say a nameless, faceless city. People in Southern California, I think, eat very healthily. I mean, there are good fats. I mean, people know about like avocado and nuts, and they're eating very healthfully. I think when I think about what my dream diet would be, if I could have everything that I wanted in a personal chef and like all this stuff, I'd have a really, a very largely plant-based diet. And I would have a lot of protein from plants. And I think when I think about like the Mediterranean diet, I mean, there's still like fish and there's some lean meats in there. But when you think about those diets, they're really heavy in good plant-based fats. And there's just such great research showing that patients that have a lot of that in their diet fare better, not just from a cardiovascular perspective, but from a cerebrovascular perspective, from an immunity perspective, from a gut perspective. There's a lot to be said for your global health with good plant-based fats.
And if you do want to just indulge and have that great steak, just do it in moderation. Sort of the
Absolutely,
right?
Well, yeah. It's funny. We had a speaker for one of our women's heart symposiums. We had Dr. Arthur Agustin, who is he developed your coronary calcium score, which is actually called the Agustin score, but he also famously wrote the South Beach diet. And the South Beach diet is kind of heavy in like the Mediterranean concepts, but he talks about meat, and he talks about good meat. And he talks about how it's not really complicated. He went into these villages in Africa where, there were wild animals, like, kind of eating the grass and not being, kind of confined. And I don't know, my husband would call them happy cows or whatever. And so, the people that were eating these meats were not having coronary artery disease. So yes, you can have some meats in your diet, but I think, there's good meat and then there's not good meat. I mean, it's kind of, there's everything in between. So I think you do want to make sure that the stuff that you put in your mouth on a general basis is good for you. Obviously, everything in moderation.
Speaking of diet, there's something called resveratrol, and it's in red wine. And I figure it's almost 7:00, so we can have some wine, right? And
it's happy hour somewhere.
It's happy hour somewhere, exactly. Can you talk about the impact that alcohol has on the heart? Again, the word moderation, but also, is this a myth? I mean, is red wine good for your heart? Every couple of months we hear a study that it is, and then we hear that it isn't, or caffeine's bad for your heart. Can you clarify and clear up some of the myths?
Right. Well, I think of it like there's like the pros and there's the cons. And I think for like you've said, for every good study, there's a negative study. That basically means the jury is kind of out. So you can kind of make your list of your pros and make your list of your cons and kind of figure out where you can do this so that it can be in moderation. There are great properties to wine. And so in the grapes that are used for wine, there are these properties that are really rich in antioxidants. And so there are great antioxidants that you can get from wine. And, I think a lot of people do like to drink wine. If you look at the Mediterranean diet, it's actually in the food pyramid for the Mediterranean diet is red wine, but they're mostly using it as that is your sweet. And so in the cons column is the amount of sugar that you can have in your wine. And if you look at wine, and perhaps you could wax poetic about the sugar amounts in wine, there are certain wines like white wines that have higher sugar amounts in them versus like richer, deeper red wines, where it's my understanding that there's less sugar in them. And so I think the cons column generally comes from the volume of wine that people are drinking and the amount of sugar that they're getting. If you're somebody who can happily have a glass or two of wine at the end of the day, and that's, your liver is fine and everything is okay and you're not driving home, I guess I should probably, be the one to say that, then a little bit of wine is probably great for you. The flip side of it is if you're somebody who, is watching your sugar intake or you're somebody who doesn't just have one or two glasses or you're somebody who has a lot of wine that is very sweet, you may be putting a lot of sugar in your system at a point in your day where your body is really not burning that fuel, that sugar, which is kind of what we usually have sugar for. And so I kind of think of it, I hope that is correct, in people's minds. It's a pro and it's a con, and everybody has to understand where they have more pros and cons. Well, they go for the wine. If they have more cons than pros, well, can you modify it such that the pros will outweigh the cons for you?
Well, I think if you're drinking California wine, you're looking at around, at least Napa Valley, you're looking at around 14.5% alcohol. If it's a greater alcohol, there's more sugar in that wine. Sugar obviously converts to alcohol. So in this Cabernet, you get, it's 14 and a half. And it's actually the same in most white wine too. But I was asking about the resveratrol because I've read so many studies that say, it's good for you. A glass of red wine, maybe two. It's okay. All in moderation.
Right about now.
Sure.
And that would be a great idea.
Anyway, thank you so much, Dr. Weinberg. This has been very informative, and I hope that we answered everyone's questions. I know you certainly cleared up a lot of myths surrounding women's heart health, and it is something that obviously we all need to be concerned about. not just at every age, And you've given us some great information going forward today. So thank you for taking the time, and thank you to everybody who joined on this call today. We will put Dr. Weinberg's contact information on the Facebook page, the Women's Health and Wellness Institute Facebook page. So if you have any other questions or would like to become a patient of Dr. Weinberg's, you can contact her. So thank you so much for your time today. And I do want to promote for next week, next Thursday, Dr. Tiffany Grunwald's informative hour on women's health. The guest will be Dr. Lisa Vidato. She is an anesthesiologist at St. John's, and she will be talking about the myths surrounding anesthesia. So look forward to that next Thursday at 6 o'clock. Again, Dr. Weinberg, thank you so much for your time, and thank you to everyone for participating. And Tiffany will be Dr. Tiffany Grunwald. I just call her Tiffany because I know her so well and I'm so privileged to know her, but Dr. Grunwald will be back next Thursday. So thank you all.
Thank you so much. Bye-bye.
Bye.